All right, let's talk a little bit about necrosis specifically. So necrosis, we're going to differentiate from apoptosis because necrosis is usually going to be an unprogrammed cell death. Okay, in other words, there is usually some external reason why the cell is undergoing destruction or undergoing necrosis. And because of this, we're going to see some very classic findings. So usually there'll be some type of inflammatory reaction. We might see cellular edema, and the cellular edema usually because there's significant injury to the cell wall. Okay, pretty significant injury where we have the leak of cytosolic enzymes. And these are all things that we kind of touched on in the cellular injury video. But again, these different forms of necrosis, there are some key things you want to take away from each of them as it sometimes comes up in questions. And so the first one here is this coagulative necrosis. If you're ever in a situation and you have no idea what type of necrosis they're asking about, usually it's going to be coagulative necrosis. Now, again, there's exceptions to that. There's a lot of specific things you want to remember about each of these, but for coagulative necrosis in general, this is going to be kind of your number one cause, and it's usually due to ischemia. Classically, a myocardial infarction, it would be something that would cause this type of necrosis. And essentially, coagulative necrosis is happening again because we have decreased oxygen perfusion to some tissue. That's going to cause a drop in your ATP levels, and because of that, you're going to have complete disruption of your electrochemical gradients, and a lot of that is going to lead to this increased level of intracellular calcium, like we talked about. That increased level of intracellular calcium is going to cause destruction from activation of lysosomal enzymes inside the cell, eventually causing edema, can lead to cellular wall injury, as well as this increase in intracellular sodium ions because of the disrupted gradient. Again, you need this ATP to pump ions out of the cell against their gradient. When you don't have ATP, right, when you don't have this, all of a sudden now you're going to have a disruption of your gradient, leading to water influx in the cell and eventually injury. Okay, and so this is what we see classically in myocardial infarctions. Now, for almost any tissue that has ischemia to it, again, if you have to play odds, it's almost always going to be coagulative necrosis. However, the exception here is going to be the brain. In those situations, we actually would call it a liquefactive necrosis. Okay, so a liquefactive necrosis is going to be a little bit different. Now, the liquefactive necrosis, right, which is going to be associated more so with cerebral injury or cerebral ischemia, this is because we have a very high release of these hydrolytic enzymes or hydrolases. These hydrolases actually cause the neural tissue to liquefy. Okay, so you get neural tissue liquefaction, which comes up quite frequently actually because it's kind of an exception to this rule about ischemia. Okay, so just remember, if it's ischemia to almost any organ, it's going to be coagulative necrosis. If it's to the brain in particular, though, if it's a stroke, we would think of this more as a liquefactive necrosis. Now, the other example here is pancreatitis, because again, it's the same reason. You have a lot of the release of these hydrolytic enzymes to the point that you start to liquefy the tissue. And bacterial abscesses are also relatively high yield. All three of these are going to be your big three for liquefactive necrosis. Now, occasionally, they'll ask about acidic solutions versus alkaline solutions. So acidic solutions tend to be more with coagulative necrosis. And if you watch the video on cellular injury, right, you remember when you have hypoxia, eventually what happens is because of this decreased ATP, you can't get down to the electron transport chain, right? So you shunt a lot of your glucose down into glycolysis to eventually form lactic acid. This lactic acid leads to a lactic acidosis, right? And we already said in almost all tissues, when you have decreased perfusion, low oxygen levels, low ATP, right, you end up with an inflammatory reaction, cellular edema, cell wall injury, and a lactic acidosis, right? Because you're shifting your biochemical pathway because you don't have oxygen, you don't have a terminal electron acceptor. So this leads to an acidosis, very similar to what you see when you expose a patient's tissues to acidic solutions. You get a similar type of necrosis, okay? However, if it's an alkaline solution, then it would actually cause the liquefactive form. So that's kind of how I remember it. I remember lactic acidosis from ischemia is going to be more associated with, in general, coagulative necrosis. And then I remember that alkaline is then liquefactive. The caseous necrosis is going to be most classic for tuberculosis. Okay, that's probably the highest yield one on here. Essentially, caseous necrosis is really just a type of coagulative necrosis. We kind of talked about this a little bit in the immunology section, but essentially what happens is if you have a bunch of, these are my acid-fast bacilli. I'll just put AFB here. So this is your tuberculous pathogen. Essentially, in very simple terms, right, we form a granuloma to essentially wall off these organisms. And so we have a lot of different type of epithelioid macrophages and giant cells, etc., that are all kind of sitting around here. And these macrophages are going to be releasing substances out here into the extracellular space that's going to be very toxic. And so they're going to start to destroy all the cells around them. Okay, so they're going to start to destroy all the cells kind of around here. And so what happens is you get these areas where there's, cells that were destroyed because of these enzymes that were released by the macrophages, right, in an attempt to clear this area out. So you end up with necrosis in these areas. And that's exactly what you see here. You can see this lymphocytic infiltrate here kind of on the periphery, right? Around here, you see all these kind of blue dots on the outside. And then you have this completely empty space in here. And so that completely empty space is representing all of this necrosis. And so if we have a caseating granuloma, we'll typically see necrosis in the granuloma in this region, okay, which is actually very classic for tuberculosis, where we see caseating granulomas, caseating necrosis. And so that's what we see here. Macrophage isolates the pathogen, right? So it doesn't spread because we can't destroy it, right? So it's doing all that it can to just isolate it. We end up forming a granuloma, a caseating granuloma, and that's because of the necrosis from releasing all of those enzymes. And eventually this can lead to granular debris. Okay, and we see this with TB, also very classic with multiple fungi. I won't go into all the details here, but TB is definitely the highest yield on the list. And if you look at this on gross pathology, it's typically said to have a cheese appearance. Okay, so you can see here, this is kind of what they're talking about with caseous necrosis. Now you might be saying, what about like sarcoidosis, right? So sarcoidosis, we always say that this is a non-caseating granuloma, right? This is a non-caseating granuloma. What does that mean? Well, that is telling you, again, the caseating is referring to the necrosis, right? The caseating is referring to the necrosis. So in sarcoidosis, we don't see this acellular pink area of necrosis in the granuloma. So that's a distinguishing feature, a caseating granuloma from a non-caseating granuloma. Okay, so sarcoidosis would not be an example of caseous necrosis because you form a non-caseating granuloma. Gangrenous necrosis is definitely something you probably see clinically at some point, usually from limb ischemia. Usually these are patients with really severe peripheral artery disease, and eventually what will happen is you get ischemia usually to the distal limbs unless they're throwing like an emboli or something like that. But usually distal limb ischemia, right, they'll call this dry gangrene. And this is really, again, another example of coagulative necrosis, but sometimes it's asked about in its own category because it's primarily affecting the limb. Now, if this dry gangrene gets infected potentially, then we would call it wet gangrene because it will have more of a liquefactive appearance. So wet gangrene would be an example of coagulative necrosis, right, from the underlying gangrene, but then there could be a liquefactive component from bacterial hydrolases, right? That's what we talked about in liquefactive necrosis. And so again, if there's a super infection, right, if we just say there's a super infection of the dry gangrene, that would be very classic for wet gangrene. Now for fat necrosis, usually there's two major causes of this. The first one is enzymatic breakdown or traumatic breakdown of triglycerides. So what happens is, again, when you start to break down triglycerides, right, you lose the glycerol backbone, you have all of these fatty acids that start to bind up to your calcium, and you end up with fat saponification. Now again, you have to remember where the necrosis is, right? The necrosis in this case is of the fat. And so typically the fat cells will not have nuclei. Normally your adipocytes, right, they're going to have their nuclei usually kind of in the periphery, okay? And then they have a lot of, this whole area is kind of filled with fat. I know it's kind of hard to see, but a lot of these adipocytes here don't really have peripheral nuclei, okay? So you start to lose the peripheral nuclei and you start to get kind of these like unclear borders to a lot of these fat cells. And so a lot of this is a result of fat necrosis. And usually you don't have to be able to recognize the slide with fat necrosis, but I would say if they asked a question about necrosis, and let's say, one option is coagulative, one option is liquefactive, one's caseous, one's gangrenous, one's fat necrosis, and they show you an image of fat cells, right? You have to at least be able to recognize that these are adipocytes, right? That's the important point, okay? And again, if they don't have nuclei, if they're irregularly clustered, if you start to see, dark blue staining throughout, that can also be indicative of this fat saponification. Those would be very classic findings. And if we were looking at this on gross pathology, we have a chalky white appearance. Again, a cheese appearance for caseous, a chalky appearance for fat. And you'll sometimes see this talked about with dystrophic calcification. Dystrophic calcification is happening when we have damaged tissue, particularly damaged adipocytes. Okay, and the reason for that, we kind of just said this, the fatty acids that are released from the triglycerides bind to calcium. And so calcium is going to start to get kind of bound up in these areas of fat damage, right? And so these damaged adipocytes are going to start to bind to this calcium. And this is an example of dystrophic calcification. The dystrophic is basically referring to the tissue. Okay, so the dystrophic is referring to the tissue. So I have a damaged tissue, that being the adipocytes, but these patients usually don't have issues with their serum calcium levels. Their serum calcium levels are normal, right? But they have damaged adipocytes, and so this calcium is then binding to all of those free fatty acids. This is the opposite of metastatic calcification, where you have abnormal serum calcium levels that are depositing into normal tissues because they're so high in the serum, and we'll talk about that. We have an upcoming video on that. Again, classic example of fat necrosis, similar to what we saw with liquefactive necrosis. We can see this with pancreatitis and also with breast tissue injury, right? There's usually a lot of fat in that area. But really, any area of the body potentially can undergo fat necrosis, especially if it has a higher density of adipocyte content. Okay, and the last thing on here is fibrinoid necrosis. So usually for this, we're talking about the blood vessels, particularly the small vessels. And really the best example of this, and we talked about this a lot in the immunology section, are these type 3 hypersensitivity reactions. Essentially what's happening with a type 3 hypersensitivity reaction is we're getting these antigen antibody complexes that are going to start to deposit into the tissues. And so all these antigen and antibodies are going to kind of come together, and they're all going to get deposited, right? If this is my blood vessel, they're all going to start to get deposited into the walls of the blood vessel. Okay, so it's going to start to get deposited into these walls of the blood vessel, and this can lead to an inflammatory reaction in the wall of the blood vessel, and we call that a vasculitis. Okay, and so what happens is these walls start to get very thick, okay, from a lot of this inflammation and antigen antibody complex deposition. Again, because of this inflammatory reaction, we start to get very high levels of fibrin also that will start to be deposited in this wall as well. One of the classic vasculitides would be something like a polyarteritis nodosa, but you can really see this in a lot of different autoimmune phenomena as well. And you can see in the image here, we have, a blood vessel. So here you can see the blood vessel wall here on the outside. And you can see it's very eosinophilic, very thick blood vessel wall. In the center here, you can see these are all red blood cells. So here's kind of the lumen in this region, okay? And then we have this really thick wall of a blood vessel. And again, in a lot of these situations where they're asking you about different types of necrosis, if they show you a granuloma, you're immediately going to start to jump to a caseous necrosis, right? If they show you adipocytes, right, you might be thinking fat necrosis. If they show you, a vessel like you see here, a very thick vessel that has hypereosinophilia in the wall of the vessel, right? It's very thick. You might be thinking more of a fibrinoid necrosis. So a lot of it is really just being able to recognize what type of tissue you're talking about. And when in doubt, if you really have no idea, if you're just going to play odds, I would go with coagulative necrosis.